Great. So I'm so excited to have this webinar today from Steve and Rita and Andy. We'll go through some housekeeping first. We're fortunate that Optum sponsors these webinars through a donation to N.A.P.S that makes these all possible. So we want to thank them very much. We are recording the webinar and it will be posted on our website. I don't believe in what's being seen now, the chat. I don't have the chat on this, so it won't be recorded. Definitely everyone joining, please turn off your video and you will be muted too. Everyone's video will be off for this. And we'll use the chat mostly to communicate so that we don't get a lot of background noise interfering with the webinar. If you're having trouble finding the chat, if you go to the bottom of your screen, it should bring up the toolbar. Gail, can you turn off your video, please? This is how you get to the chat, and you can send a message to everyone, or you can also select anyone that's signed into the webinar and send a private message to them. All right. Gail Black, can you please turn off your video? So there is certificates available for the webinar. We give certificates to members of N.A.P.S. At the end of the webinar. If you send me an email at this email, membership@inaps.org, I will send you a link to the short quiz, and when you complete the quiz, I will give you a certificate for attendance at the webinar. There is often some confusion. If you're on our mailing list, you're not necessarily a member. So a member is that you've paid dues in 2018 or you're a lifetime member. And you need to be a member to get a certificate of attendance for continuing ed. Gail Black, can you please turn off your video? I'm so happy today to have our three presenters. Steve Harrington is the founder of N.A.P.S. and was our executive director from 2004 through 2015. In addition to being an author, lawyer, a keynote presenter many times, a small business owner, and a conference organizer, Steve was key in the development of the SAMHSA-funded Recovery to Practice training project, and of course, the National Practice Guidelines that we're going to talk about today. In 2015, Steve stepped aside for medical reasons, but he remains involved with us today. Rita Cronise worked with Steve for several years, both on the SAMHSA funded Recovery to Practice training project and with the team that developed these National Practice Guidelines. Rita served as Director of Operations for N.A.P.S. after Steve stepped aside. She's now working for Rutgers University, where she uses her background in training design to develop the peer certification in her home state of New York. Andy Bernstein is a clinical and community psychologist with a long-term interest in the consumer movement and in peer support as a helping paradigm and in an evolving discipline in workforce. Andy has been involved with N.A.P.S. since 2006 and has served as vice president and conference co-chair and is currently a board member. Andy is a clinical professor in the University of Arizona Department of Family and Community Medicine, where he supervises interns and residents in their communication skills with patients, and he serves as clinical director of Camp Wellness, a recovery-oriented adult education program which employs peers as health mentors. So with that, as soon as I can here, I got to get my menu up. Just a minute. I'm going to give control to you, Andy.
Okay.
And you should be able to take it now.
Okay, I'm trying to find where
bottom corner.
Bottom corner.
The little arrow. Do you have that?
No, I don't see a little arrow.
If you put your cursor in the bottom left corner, you should get the arrows.
Yep, now I see it.
Thank you.
Okay, so the objectives of today's webinar are to identify the differences and the overlap between the professional paradigm of help and the mutual paradigm, which is natural peer support, especially when the latter is provided in paid work settings. We would also like to be able to recognize the tensions that arise when this overlap between these paradigms makes it difficult for peers to be completely true to the core values of peer support. We'd like to identify ways in which applying the national practice guidelines can help to resolve these tensions and can lead to continuous learning and improvement for people who work in settings in which their lived experience is being called upon. And also to recall the key factors that led to the development of the National Association of Peer Specialists, which used to be the initially was the National Association of Peer Specialists and then became the International Association of Peer Supporters and the National Practice Guidelines. And we'd like people to be able to understand the process that was followed for gaining the widespread agreement and the adoption of the practice guidelines. Moving forward, I'd like to do, let's start with a very brief history of the helping professions. This is being done now at a time when our own profession of peer support is really becoming one of these professions. It used to just be peer support happened, but now we're becoming one of the professions, and I think the Recovery to Practice project is one of the turning points in the evolution of peer support when it became recognized nationally as one of the helping professions. And that's why we're looking at standards, because standards, as we'll see several slides down the road a little bit, are rules or guidelines which are used as the basis for informed decision-making about what is acceptable work, what are performance and practices that are established by an external entity, some authoritative group or some body which decides what constitutes proper practice. So let's see if I can advance. I've got a bar at the bottom which is getting in the way of the arrows, but there we go. So that went too far. Before professional help, there was people just helping each other. Before there were professions, humans just helped each other. People helped each other because they learned how to do it. They knew how to farm, they knew how to take care of animals, they knew how to make clothing, and they taught each other how to do these things, how to make tools, how to heal wounds, how to comfort unhappiness. Sociologist Thomasina Borkman talks about the difference between experiential knowledge and professional knowledge. Professional knowledge being knowledge that comes from books, as opposed to experiential knowledge, which comes from lived experience. So professional knowledge, really, books and other knowledge that's passed along through reading, really got a boost when the printing press was invented, and it made publications available to everyone. And of course, this led to the dissemination of knowledge and formal training, which itself led to expertise being shared and developed. And this is something that became part of the Industrial Revolution and the evolution of the class system with professionals, apprentices, learners. And along with that came accountability to third parties, which is kind of what standards involved, which is what standards are all about. where people became accountable to other entities, not just each other in mutual support. So educators became involved in teaching people how to help. Certifiers decided who was allowed to help, and geographic regions decided you can help here, but you can't help there. Payers, we began to distribute the risk and the payment plans. Insurance companies got involved. And as the professions distinguished themselves, psychiatry, psychology, social work, counseling, nursing, all of these different professions established a way of protecting the income and protecting the rights of their members to earn a living. And as that happened, the standardization of each of the disciplines and the professions led to best practices. And of course, at the same time that people became responsible to provide service in a certain way to the consumers of those services, that led to a distancing between the people who were helping and the people who were receiving help. So it wasn't just two people helping each other in an equal kind of way, but rather the people who had the power and the professional knowledge and the people who were receiving help. And this led, of course, to the kind of commodification of the helping industry, which began to feel more like it was serving its own interest rather than the interests of the people who were receiving help. Let's take a minute now. This is a slide which quickly moves through the development of consumer empowerment and the development of peer workforce. I don't want to spend a lot of time on this because we're gonna cover this further into the webinar. So let's move to the next slide. Martha, if you can advance it. The arrows have disappeared from my, oh, there they are again. There we go. So there's a kind of helping paradigm continuum, which I want to talk about. The pure professional model versus the pure mutual help model. Distinguishing them and then recognizing that we now have a little bit of overlap. So in the pure professional model, we have book knowledge in contrast to experiential knowledge of pure mutual help. Expertise is defined in the professional model by formal education and credentials, in contrast to defined by lived experience. And who's the person who's had the most experience doing this work? How much experience do you have in whatever it is that you're helping someone do? In professional model, you get paid to do the work that you do, and that's how you earn a living. Whereas in the pure self-help model or mutual help model, there's no money involved. If you think about 12-step groups, 12-step model, there's no money exchanged in AA or any of the other of those groups. People help because they want to help each other. It's totally done for the love of helping. There's unidirectional accountability in a professional model, and that's very different than the bidirectional accountability that exists in a helping dyad, which is pure mutual help. There are clear boundaries and fixed roles in a professional helping relationship, whereas there are more flexible boundaries and complementary roles where people take turns helping each other in a mutual situation. Also, power is defined a priori, before the relationship starts. You walk into someone's office seeking help, that person has a power that you don't have as a help receiver. Whereas in mutual help, the situation defines who's got the power, and the power is again related more to experiential knowledge and lived experience. And then again, in professional models, external regulations determine what's acceptable behavior, what's acceptable practice. Whereas in mutual help, there's no regulation. It's up to the two people exchanging help to decide what's okay and what's not okay. This is getting complicated now because, as we know, many peers are employed in situations where they are in a traditional employment setting and they are being paid to provide services. Larry Davidson does a really nice job in another webinar, number 19, I believe, of tracking the evolution of peer support as it's become part of traditional work settings. And I strongly recommend that people who are interested in the evolution of peer support take a look at that webinar. It's on our website. Consumer empowerment and the mutual help values and ethos are now becoming part of traditional work settings when they are enlightened enough to want to use peer support. But this kind of hybrid model creates tensions, and people are finding there's some confusion because all of the essential elements in professional models are not necessarily consistent with the elements of pure peer support. So the tension that people experience when they are being paid to do work as peers, whether they are being asked to talk about their lives and their experience, or whether they are being asked to do things that typically peer support should not include, like driving people around or encouraging them, coercing them to take medication or to come more regularly to their appointments. That's not peer support. And sometimes peers are being coerced to do those kinds of activities. So part of what we are hoping this webinar can accomplish is to help people understand what it is that the profession of peer support embodies and what peer support in its purest form means, even when people are being employed in traditional settings, so that people who are working in the discipline of peer support can recognize what good peer support looks like, even when they're working in settings that are not peer-operated, consumer-operated, family-operated settings. And this confusion is something that's become a really important problem, a significant problem for people who are working in these settings. So I'm going to turn the mic over to Rita, who's going to talk a little bit about the history of peer support services and how peers got more and more involved in delivering help in traditional settings. Go ahead, Rita.
Thank you, Andy. That was a really good rundown of, the difference between paid and between professional support and mutual self-help. I'm trying to see if I can get little arrow here. I had it, and now I don't see it. No. There we go. Whoops. There we go. I may have to ask you to help me with this one, Martha, because I'm not seeing the arrow. Oh.
You want to go back?
Yeah, let's go back. One more.
There we go.
Okay, thank you. So I'm not going to be able to do justice to the whole history of the peer support movement, but what I wanted to do is just sort of focus on the clubhouse model as sort of one of the very first initiatives from which the consumer-operated services sprang, because it was one of the first efforts where people were employed, and it may not have been employed for pay, it may have been employed to become, to gain expertise and skill in certain things, but the clubhouse model became one of the very first models where peers were contributing to the community and sort of early employment initiatives because they were working on employment skills in that as one of the earliest models. I also wanted to mention that there's a really strong consumer survivor advocacy that went through this, and if you're not aware of the history, there's actually a really good 4-part series that Pat Deegan has on her website called The Politics of Memory, which kind of steps through a lot of the early consumer survivor movement initiatives and the things that they accomplished. And Pat Deegan also had not too long ago done a webinar for N.A.P.S. Both of those are really good places to start if you're not really aware of the consumer survivor history. But because of the consumer survivor movement, the National Institute of Mental Health came around to fund consumer support programs in 1977, and they had 14 demonstration consumer-operated service projects, which were some of the early peer-run organizations. in 1988. And one of those, Andy is actually very familiar with, and I've gotten to know a number of people from there as well, the Collaborative Support Program of New Jersey. This is just one example. In the late 1980s, it was paying consumer providers to run drop-in centers, which were later called self-help centers, and these were distributed throughout the state. So these were some of the early initiatives where people who had lived experience were getting, jobs to provide support using their lived experience. Not necessarily related to peer support directly, but there was training for consumers to become case managers in the state of Colorado, and that was another one of the earliest paid positions for peers in the system. And then later on, of course, the Georgia Certified Peer Specialist Project came about, which was one of the earliest models where they were looking at getting funding directly through Medicaid for the services the peer supports were doing, and Pennsylvania followed soon after the Georgia model. So that was some of the just early initiatives on peers getting jobs in the system. There's actually another whole history that goes along with that, because there is this whole dynamic tension of what are the core values of peer support and peer mutual health self-help versus what's happening when you get paid in the system and have to do certain jobs that may or may not always line up completely with the values of peer support. There's a very good article in Mad in America that Darby Penny put out called Who Gets to Define Peer Support Anyway? And I would really recommend that as well as a great, look at this kind of dynamic tension between the pure self-help versus the paid peer support and, where we've come to today. All right, now let's see if I can go forward. There we go. So, of course, many people are aware that in 2007, Dennis Smith, who was the CMS director of Medicaid at that point, issued a letter of guidance to the 50 states on recognizing peer support as an evidence-based practice, and as an evidence-based practice gave certain guidelines for creating Medicaid approved programs. So they had to have a state-approved training program for peers, and they had to have supervision by a qualified mental health professional. Those were the main guidelines that came out of that particular guidance in 2007. So at that point, each state that decided to create a peer support program, they determined what their training was, and then they determined the credentials for supervision. But the issue was that the way that Medicaid was done in each state was different. So the professions and the ways that they were paid, and this is not just peer support, but this was all of the professions, from psychiatrists to psychologists to social workers to all of the professionals that were being paid through the Medicaid system. There were different requirements in every state for all of those different professions, and to open up the state plan again to include peer support was sometimes a challenging thing in each of the states. So often people say, well, why can't we just have one standard for all of the states? A lot of it's because each state was doing things differently and had to do things differently because of the way that their state plans were written. So at that point, as we moved from 2007, when the first letter of guidance was issued, up to more current times, many states, but not all, were using sort of the Georgia model for training and certifying peers. But that, because the states were looking at different requirements, the guidance in each of the states was different. The supervision was different in each of the states. Some requirements for supervision were that you had to be a licensed professional, and others were looking at qualified mental health professionals differently. I know that some states were at one point taking the psych rehab certificate, the certified psych rehab practitioner, as a qualified mental health professional who could supervise peers. Others would not recognize that particular credential. So there was a great variation in how supervision was looked at, which also had a big impact on the way that peer support was done in the different states. And much of the guidance that was provided to the different peer specialist programs were based mainly on liability concerns and the things that they wanted to make sure peers were not doing. Thou shalt not do this, rather than really articulating what good peer support looks like in practice. So those are the kinds of things that were happening at the point in time that we were looking at developing standards for peer support. But I want to take just a slight step backwards and allow Steve to talk a little bit about what was happening when he first started I.N.A.P.S, how I.N.A.P.S, or how, the National Association of Peer Specialists, which was the forerunner of I.N.A.P.S, how that got started, what he was doing to kind of gather support, throughout peer specialists that were working in the field. And I'm just going to go ahead and turn it over to you, Steve, and let you talk a little bit about the early days of the National Association of Peer Specialists and the Recovery to Practice project.
Okay, can you hear me?
Yep.
Okay. Gosh, a little going back in history. But before we do, I just want to explain real quickly that about 3 years ago, just before a conference, of course, the timing was terrible, I had a stroke, and people stepped up and made that particular conference happen. And because the stroke left me with partial vision and an inability to read and some other issues, it was really important, and it was just amazing that it happened the way it did. And I am now busy fishing and canning tomatoes. I've got a big garden. There's life after peer support. And so I just wanted to mention that, because some people have expressed some concern, and I just want to tell you, life is beautiful, and I live on a little lake, and I'm going to go fishing again this afternoon. So let's move into peer support and what, how the organization formed. And what happened was there were, it wasn't, I was only one person. There were a lot of other people involved. There were actually seven of us that were hired together at a particular agency in Michigan, and we just said, gee, I wonder what other people are doing, other peer supporters are doing. And so we said, gee, maybe we should have an organization. And it wasn't formed just by me, because people came from all over the United States to, they started calling and emailing, and before we knew it, it was like a wildfire, a good wildfire. And so we quickly discovered we were onto something. And we cooperated with a lot of people and had communication quickly with people all over the country and actually beyond. And the need seemed to be people wanted to find out what other people were doing and how they were doing it, what worked and what didn't work. So it was really mutual, it was really peer support for peer supporters, and through an organization. And we had started having conferences. We thought it would be years before we'd be able to have a conference, but because of the interest and the enthusiasm, that happened. I think it was, we were only formed 2 years before we had our first conference in, I believe it was in Denver. But anyway, we had our first conference that went really well. We learned a lot, of course. And so the conferences were really a focal point, as well as a newsletter. And we created a newsletter that people contributed to, and we shared our experiences and shared what worked and what didn't work through the newsletter. So that was really an important aspect too, that kind of gave us some glue, some cohesiveness. And that was pretty exciting. And it was all done on a volunteer basis. This was not a paid thing. It wasn't even volunteer. We had to, we contributed a lot of our own meager funds to make a lot of things happen, and but it did. And so that's how the organization really got started. It really, I guess, it grew out of the need, and apparently there still is a need, and that's a good thing. So I can't remember. Maybe Rita knows exactly how many years ago it was that we did the practice standards. What we did was we got a grant through SAMHSA to create a recovery curriculum. And very early on, it was observed that the whole profession was so diverse and people were doing so many different and wonderful things that we needed some idea of some framework to create the curriculum. We needed to have a better understanding of who we were. And so to do that, we started a project that was, of course, totally unfunded, to gather input from peer supporters across the country and find out what it was they were doing, and how they were doing it, and why they were doing it, what it was that was going on across the country. So we had, we had written surveys, we had online surveys, we had focus groups. We did a number of focus groups across the country, and we reached out to get as much input as we could. And when we started getting the same thing over and over again, we realized, well, I guess we'd covered that area. And we ended up with, I believe it's 10, is it 10 practice guidelines, Rita?
Yep, that's where we started, and we ultimately ended up with 12 after the SAMHSA meeting. But yeah, we started with 10.
Yeah, and it was really interesting because it helped us. That whole process really helped us understand who it was we were as an organization, and who our members were, and we realized that it wasn't all about strictly mental health. Their substance use disorders were actually, in some ways, had a better understanding of who they were and how they did what they did, and they seemed to have more structure, but there was still some disorganization that we could learn from and help support organizationally. And then we realized that there were people who support other people in so many ways, and of course not all of it's paid and doesn't have to be. It's not all about getting paid. It's about having a philosophy of life that is about seeing the world as one community, and seeing how we fit in to a larger community as a valuable member and someone who can do something good for other people, something really, really meaningful. And that really was what distinguished us. And so the practice guidelines, again, were really important because it helped us understand who it was we were. And we really had to do that as we did the recovery curriculum. And that's when Rita stepped in, and a few other people, but Rita was huge. She came in just at the right time and said, gee, can I help? And boy, could she. And she did. And but so she really helped with the curriculum that we had to put together. But at the same time, we were also, trying to figure out who we were, and we had all this wonderful input that helped us understand that and express that so that we could help others. And the practice guidelines we put together were not intended to be written in stone. We expected that they would evolve and they would be refined in ways as peer support grew and evolved itself. Is there anything else I should be covering there, Rita?
No, that was beautiful, Steve. And I'm going to cover some of the same ground, and I may just ask you to add a little more detail to because I'm just going to walk through, only because I wanted you to have the freedom to say it as you wanted. I'm just going to put it, kind of in a more chronological structure as we go forward. About N.A.P.S was started in 2004, as you said, by a dedicated group of about 7 peer specialists in Michigan. And Steve was kind of the ringleader of the group. You did a lot of outreach across the country to peers through your newsletter, through your educational pieces. And then you did a survey of the membership in the early days, I think it was around 2007, right?
Yeah.
Where you did, you did a survey of the entire membership at that time.
Yeah, I forgot about that one. But that first survey, I think I can't remember the number of responses, but it helped us as we went forward, helped us understand who we were. I mean, we really had to figure that out. Who the heck are we? And then how do we handle the diversity of duties and experiences? So, yeah.
Yeah, and so you did the initial survey of job satisfaction and compensation, I think it was, satisfaction and compensation. And a few years later, fast forward to the project that immediately followed the National Practice Guidelines, was a repeat of this survey, but we didn't know the education level of people. So we did another survey later that added what is your education level coming into your work as a peer specialist, and that was really enlightening too. But that first survey was like one of the groundbreaking and first information about who peer specialists were, what they were being paid. That was an early eye opener, and how satisfied they were with their work. It was a great survey. And as you mentioned, the first national conference was in Denver in 2006. I just have a rundown of the conferences up to Philadelphia in 2012, which is kind of where we had this amazing groundswell of people that were just saying, there's just no consistency in the guidance that we're getting. So we really want you. They kind of like shook us and said, do practice standards, please. So we were actually responding to the people. Up to that point in time, people were asking for it, but in Philadelphia in 2012, that was where there was a whole group of people that pretty much were going to lynch us if we didn't do something. That we got the grant for the Recovery to Practice project. I think you got that in 2012. And that, if you're not aware of what that was, it was grants that went to all of the professional associations, the psychiatrists, the psychologists, the social workers, the psychiatric nurses, the addiction counselors, and N.A.P.S were all given grants to develop recovery curricula to help to integrate more recovery-oriented practices within. It was kind of crazy that we were getting a recovery curriculum, but we really took it to say, okay, people have had a first level of training through some of these different models, like the Georgia model, a core level of training. What comes next? So we were looking at, and Steve did a situational analysis. The situational analysis that you did, Steve, you went, across the country asking people, what other training do you need? What are the issues you're facing? What skills do you need to build? I think that was a lot of what you were asking, because that kind of predated me.
That was right, just slightly.
Yeah.
But yeah, no, I think it's important to understand that for a lot of people in the mental health field and related fields, we kind of came out of nowhere. And the whole thing seemed very new to them, even though peer support, you could trace that back to biblical times. So, but to have it more organized, more formalized, we were a new critter.
Right. And so both the N.A.P.S and DBSA were awarded a subcontract to develop that training for peer specialists. But as we were developing the training, because of the situational analysis you had done, and because the field itself was really demanding it, that's when the National Practice Guidelines, it wasn't something that was ever in SAMHSA's charter to do, but they were giving us an indication that we really ought to be taking this on as a project. So it became an unfunded companion to the Recovery to Practice project. And Paolo Del Vecchio and Wilma Townsend were the main drivers from SAMHSA towards having the national standards developed. Anything else you want to say at that point, Steve? I'll just sort of step through from here.
No,
what we sort of did.
I'm good.
Okay.
Thanks.
So just like I said, Paolo Del Vecchio and Wilma Townsend were kind of helping us to frame what exactly are practice guidelines anyway. And they're basically the rules that are used as the basis of informed decision-making about what acceptable work performance and practice is. Wilma had come out of the social work discipline and had been very aware of how social work evolved, and sort of was not telling us we had to do it this way, but encouraging us to look at that as a model for how to develop the guidelines for peer support. They're established by an authoritative entity, and they kind of all saw us as having stepped forward as, we are the National Association. So through a collaborative process, which is what we followed, to get input from a wide range of people who are performing the work to develop the standards based on values, ethics, principles, and competencies. And having a core set of practice standards is one of the best and most important ways to legitimize a field of practice. And a lot of that came right out of Wilma's playbook from some early work on consumer involvement in mental health systems. So what do practice guidelines? Actually, practice standards, which is a larger perspective, consists of three components: the practice guidelines, which is what we developed, then identification and description of the core competencies, which is something that Cheryl Gagne did a little bit later through brass tacks. She actually came up with a description of the core competencies of peer work, and then a code of ethics, which many groups have codes of ethics that are specific to the settings in which they're providing peer support. But we really looked at the practice guidelines we were looking at as these core values really define the ethics of peer support. So how did this all sort of come about? In 2007, there was the survey of member satisfaction and compensation we mentioned a minute ago. Then in 2011, Steve did the situation analysis for Recovery to Practice. So he had a document that really had looked at what is peer support at that point in time. We looked at the literature of the existing guidance documents that were out there, and we had our own Recovery to Practice curriculum that we were working with. And again, it was requested by peer specialists at the 2012 National Conference, which was in Philadelphia. At that time, there were no national guidelines for practice standards. States were not recognizing certification in other states, so there was no reciprocity between states. Supervision was all across the board in the various states. And peer workers were, because of the way that they were being supervised, increasingly being asked to perform clinical tasks, they were saying, which is true, this isn't peer support, so let's take a look at what is peer support. At that conference, we developed a task force, which I'll mention in a minute. But following that conference, we asked, we wanted to get a real, pulse of, should we do this or shouldn't we do this? And 87% agreed or strongly agreed that there should be national standards. So that was a pretty, strong indication. And then we also said, are we really the ones that should be doing it? And about 70% agreed or strongly agreed that N.A.P.S was in the best position to establish the national standards. So the process that we followed was Steve had drafted an original statement of guidelines that was reviewed by a number of peer leaders in the country at the time. Chuck Humatai was one of the very vocal reviewers who said, there's so much guidance out there on what peers should not do that we really ought to be focusing on what peers should be doing. What does it look like in good practice when peers are doing good peer support? So we took that, under advisement. Another thing that we did, because we knew we needed to reach out across the country and get some kind of consensus as much as we possibly could from a large group of people who were having a lot of different ideas about what peer support really looked like. And Steve Michio in New York, he's now, I think, the board chair at PRA, at the Psych Rehab Association. But back in the day that we were doing this, he had come off of a project of getting consensus in New York State from 12,000 people about infusing recovery into the mental health system. He and another leader, Amy Colsante, had been very instrumental in doing that within my home state. And so I reached out to them. I said, how did you do that? What was the process you followed? We kind of looked at the process he followed, and we did a very similar thing. We had a task force that did a literature review of all of the existing ethics, competency, and guidance documents related to peer support or related to good practice in direct services. And we're looking very specifically for positive actions based on the early feedback that Chaku and others have given to Steve. And that task force that came out of that 2012 conference included Nicole Dar, Mary Falla, Karen Lateau, Maureen Feeney Burns, Denise Camp, Deidre Dane, Lisa Goodell, Kim Maldonado, and Dan O'Brien Mazza. All of them were major contributors in the early portion of what we were trying to define as the practice guidelines. And I should also mention that at that 2012 conference, Kathy Cave had come to talk about a guidebook they had just released called Engaging Women in Trauma-Informed Peer Support. And some of what the language they had used in that was, fit so perfectly because it came out of the trauma-informed traditions, and so much of what we do in peer support needs to be trauma-informed. So as the task force looked at different guidance documents, they identified 10 core values that were intended to complete the just released SAMHSA Guiding Principles of Recovery, because they had 10 Guiding Principles of Recovery that SAMHSA had just released. And these core values were intended to ride right beside the Principles of Recovery as guidelines for doing peer support in a recovery-oriented way. So these, our core values are drawn in part from trauma and human rights literature. And then we took those out to focus groups, which were done some of the focus groups were prior to, some of the focus groups were done after we had identified the core values. But we did focus groups in Cincinnati, Raleigh, Phoenix, Pennsylvania, California, and New York. And I'm going to stop and breathe for a minute and ask Steve if he has anything to add to what we've shared so far.
Yeah, just one thing is that we really reached out, and I think that's a fundamental value for peer supporters is to really look at the communication issue and reach out and not have preconceived ideas and not be judgmental and that kind of thing. And that really helped. As you can tell from what Rita has been saying, we did a lot of outreach, and things are different everywhere. And I remember one fellow in particular that I was involved with. He would not talk to any mental health professionals, period. He would meet them at the door and tell them to leave. And so the case manager asked me if I would try. And I just went to his house, knocked on his door, and he said he wasn't interested. But I noticed he was looking at my car. It was an old beat-up Mercury, and he asked me a couple questions about it, and I used that kind of as a entryway. And the progress this fellow made, I mean, it was amazing. What we'd do is just go for a ride. You just jump in my car and we would talk. And what happened in that car was really transformative, and really it to this day still is sticks with me, that whole experience with that particular fella. And he made such progress and was so much happier in his life, but just such unexpected things. And, you know, if you, you know, try to, you know, in some areas, you know, that would be forbidden to have, you know, a peer that you're trying to help just to drive and ride around. But what happens in that car can be extremely important. So we try to just incorporate, you know, all possibilities and not be judgmental. And that really is important.
Great. Thanks, Steve. Good example. So moving ahead, we had done some of all that preliminary work, and we had those 10 core values that we then, in December of 2012, which was a few months after the conference and the task force had been working a little bit, we took those 10 core values to a meeting at SAMHSA where they held an expert panel. And the expert panel included members of the substance use community, recovery community, because they wanted to have additional input to make sure that the guidelines would apply equally well with recovery coaches and people that were doing peer support in the substance use arena. So we took under advisement some of the things that they shared. They had 2 additional values that they felt were important that actually fit pretty well with what we were doing too. And the work of this particular meeting resulted in 12 core values and definitions that fit both mental health and substance use. And at that particular meeting, we met with Paolo Del Vecchio, Wilma Townsend. Steve was one of the main presenters. Tom Hill was one of the main presenters. Larry Davidson was there, and he presented that history of the peer movement at that particular meeting. Deidre Dane, who was our project manager through the Recovery to Practice project. Chaku Matai was there. Stephen Samra was there. John O'Brien, Kathy Nugent, and Marcia Baker were people that were instrumental in that particular meeting. And then following that meeting, we developed an online survey that included the core values and the descriptions we had gathered from all of these different sources as they were refined and agreed upon, you know, at that SAMHSA and following that SAMHSA meeting. And we had 4 flavors of the survey that went out. One went out to the N.A.P.S membership and was snowballed throughout the mental health community to various groups that picked up our survey and then distributed it, like the National Mental Health Consumer Self-Help Clearinghouse has always been one of our prime supporters, and they helped to distribute the survey. Members of Faces and Voices of Recovery distributed it through the substance use peer recovery community. The peers at the VA, we had some really solid responses from the peer specialists who were working within the Veterans Affairs. And then we also had, out of that SAMHSA meeting, a gentleman by the name of Paolo Mancini helped us to translate the survey into Spanish, and he distributed it into the Hispanic community so that we had a little bit more of a multicultural spread with the survey. And so the results of the survey, well, actually, I'll just run through quickly. What were the core values? If you haven't seen the practice guidelines, they are, you know, there's a whole description and a whole set of guidance around each of these core values. The peer supporters are hopeful, open-minded, empathetic, respectful, facilitate change, that they are honest, direct in their dealings, that peer support itself is voluntary and supports choice, mutual and reciprocal, equally shared power, strength-focused, transparent, and person-driven. And the national practice guidelines are actually on the I.N.A.P.S website. I may, if we have time, have Martha take a look at that. Very quickly, the results that we got in these nationwide surveys in percentage of agreement, 98% agreed in the mental health community, 97% agreed in the substance use community, 99% agreed in the veteran community, and 95% in the Hispanic community. And some of that was, the lower percentage was because there were some things that were lost in translation. There were about 200 people that participated in all of the focus groups that led up to these online surveys. There were 808 people in all 4 combined surveys that participated. So the total participation in the development, review, and approval process for the national practice guidelines was about 1,000. And I'm kind of out of time, but just as you think about why do you think there was so much agreement to the core values, consider that. And then one thing about using the guidelines as an example, we had drawn upon one particular resource from the World Health Organization, which is the Quality Rights Toolkit. So when we say that peer supporters facilitate or are agents of change, when you actually dig into the description of that and what the guidelines look like, the definition is that some of the worst human rights violations are experienced by people with psychiatric trauma, abuse, or substance use challenges. And peer supporters treat people as human beings. They remain alert to any practice, including the way people treat themselves, that is dehumanizing, demoralizing, or degrading, and will use their personal story. The peer supporters will use their personal story and or advocacy to be an agent for positive change. And what I think that Steve did that was just masterful, because we had these core values and we had these descriptions from a lot of other literature, but Steve really looked and considered what the different things that peers were saying on these surveys, because there were a lot of open-ended responses, and he kind of pulled together guidelines. So the guideline that goes with peer supporters facilitate and are agents of change are that peer supporters recognize and find appropriate ways to call attention to injustice. Peer supporters strive to understand how injustices may affect people. They encourage, coach, and inspire those they support to challenge and overcome these injustices, use language that's supportive, encouraging, inspiring, motivating, and respectful. Peer supporters help those they support explore areas in need of change for themselves, because so many people experience internalized stigma and sometimes don't realize that there are ways to break out of that and, and regain health and wellness beyond, self-stigma. So peer supporters recognize injustices peers face in all contexts and act as advocates and facilitate change where possible. So putting the practice into guidelines, a few ways you can do it: share with your employer or supervisor, work on putting at least one a week into practice, use what you learn as part of your supervision. So share that with your supervisor and keep working on these. Share good examples with your peers or debrief challenges you've had in trying to put them into practice with your peers. And most importantly, one of the requirements for submitting a proposal for the N.A.P.S conference this year, the 2018 conference in Orlando, is to tie what you're doing to at least one of the practice guidelines. And I think the deadline is still to submit next week, but Martha can address that. And, thinking about how else you might use the national practice guidelines in your work. If you have questions, you can submit them through the chat or after the fact. Here's the contact information for us, and I'll turn it back over to Martha. There's references too that go with. These are different references that we've mentioned in the course of the webinar. So Martha, take it away.
Yeah, so I thank all of you who joined us today. And we did extend the deadline, and this is the first time it's announced, so you're the first ones to hear it. We're extending it by a month to September 10th to submit a proposal for the conference that's in Orlando in December. Again, if you would like a certificate for attendance today, you need to be a member. You can join through our website. It's $35 a year. That also gives you access to all the past webinars we've recorded. And if you email me this membership at inaops.org, I'll send you a link to the short quiz. And after you do the quiz, I will send you a membership certificate. We didn't have any questions posted in the chat that I didn't answer as we went along. Does anyone have anything else they'd like to add? Steve or Rita or Andy?
No, I think we kind of, I wish we had more time, because we're hoping to be able to have some discussion about that specific guideline regarding human rights and agents of change that peers can be, even in their own agencies. So we might be thinking about another webinar down the road, specifically identifying using some of the guidelines to help people change environments in which they work.
Great, thank you. And that too, if you didn't, post a question today, but you think of something that you want to ask, again, either at that email that I gave for the webinar or info@inaops.org, you can shoot us a question there, and we'll do our best to answer it. So thank you, everyone.
Super. And I just want to give a shout out to Zach. Hi, Zach. Thank you.
Zach is my partner and technical guru, so he helped me a lot.
Thanks, everyone.
Thank you all.
Thank you.